Good evening and welcome to the Diplomacy Center Foundation's virtual conversation about diplomacy during a health crisis. I'm Kelly Scandoni, the programs coordinator for the Diplomacy Center Foundation. For those who might be unfamiliar with us, we are the nonprofit partner to the U.S. Department of State in creating the National Museum of American Diplomacy, located in Washington, D.C. The museum is currently under development, but when it fully opens, it will be the nation's first museum dedicated to sharing the history, practice, and challenges of American diplomacy. Throughout tonight's discussion, you can join the conversation yourself by using the chat function on the right side of your screen. You're also welcome to ask questions to our panelists via the Ask a Question box located at the bottom of your screen. We will have a special Q&A session at the end of the conversation. Now, should we encounter any technical difficulties tonight, because they do happen, please bear with us as we try to resolve them. If your screen freezes at any time or if you lose audio at any point, try refreshing your screen and hopefully that will bring us back to you. It is now my pleasure to introduce tonight's conversation catalyst, beginning with our moderator. Ambassador Thomas Pickering is the Vice Chairman of Hills & Company and Chairman of the Diplomacy Center Foundation Board of Directors. Tom holds the personal rank of Career Ambassador, which is the highest in the U.S. Foreign Service. In a diplomatic career spanning 5 decades, Tom served as the U.S. Ambassador and Representative to the United Nations in New York under President George H.W. Bush and as the U.S. Undersecretary of State for Political Affairs under President Bill Clinton. Tom was also the U.S. Ambassador to the Russian Federation, India, Israel, El Salvador, Nigeria, and the Hashemite Kingdom of Jordan. In Washington, Tom was the Assistant Secretary of State for the Bureau of Oceans, Environmental and Scientific Affairs, Executive Secretary of the Department of State, and Special Assistant to Secretaries of State William Rogers and Henry Kissinger. After his government service, he was the Senior Vice President of International Relations at the Boeing Company, and in 2012, he chaired the Benghazi Accountability Review Board at the State Department. Our next panelist is Ambassador Sally Cowell. She was a career Foreign Service officer for more than 25 years and the founding deputy director of UNAIDS, which is the joint and co-sponsored United Nations program that was established in 1995 by the world community to address the AIDS pandemic. Following her work at UNAIDS, she served as the chief liaison officer at Population Services International, a nonprofit organization addressing AIDS, family planning, and maternal and child health in 60 low and middle income countries around the world. Ambassador Cowell retired from the American Cancer Society in June of this year, where she was the Senior Vice President for Global Cancer Control. She is a member of the Council on Foreign Relations and is a trustee of the Diplomacy Center Foundation. Ambassador Alex Laskaris has been a Foreign Service officer for more than 29 years. He was the ambassador to Guinea throughout the entire Ebola outbreak and later served as the deputy to the commander at U.S. Africa Command from 2016 to 2019. His previous posts include Consul General in Erbil and Deputy Chief of Mission in Pristina and Bujumbura. Currently, he is on the faculty of the National War College. And our final panelist is Dr. Farley Cleghorn. He's an internationally respected health diplomat and has more than 30 years of experience in international health development, research, and program implementation as an infectious disease. My apologies. He has more than 30 years of experience in international health development, research, and program implementation as an infectious disease thought leader, systems thinker, and epidemiologist. He's an expert in global health, infectious diseases, program design, and implementation. At Palladium, Dr. Cleghorn leads an interdisciplinary team focused on the holistic response to global health priorities based on sustainable health systems, implementation science, health promotion, and prevention. He has had a distinguished career at the U.S. National Institutes of Health before serving as a senior scientist and faculty member at the Institute of Human Virology at the University of Maryland Medical Center. He is clinically trained in internal medicine and infectious diseases. One final thing before I pass the baton over to Ambassador Pickering, please keep in mind that tonight's conversation expresses the personal opinions of our panelists and does not represent the views of the U.S. Department of State, the federal government, or any other organization. And with that, I will pass everything over to you, Ambassador Pickering, to get started.
Thank you, Kelly, very much, and let's get started. It's a pleasure and honor for me to join the three of you each well qualified and with a wide variety of experience. And I'd like to now open it up with some questions. The first will be to all of you. When a health crisis has occurred, what do you believe should be the immediate national and international goals for the U.S.? In what way are our foreign policy goals impacted or modified? And how did prevention and therapy play a role in dealing with our objectives in these kinds of crises? And I'll begin with whoever raises their hand to volunteer, or I'll ask one of you to start. No volunteers? Ambassador Laskaris? Oh, go ahead, Dr. Cleghorn, please.
Thank you, Ambassador Pickering. Well, I think we can classify international collaboration in infectious diseases in a number of ways, but it has been codified in our participation in the UN agencies and the international health regulations. And the international health regulations have been adopted by the World Health Assembly in 1969 and was modified in 2005 after the SARS epidemic. And we have learned a lot since then, particularly after the Ebola epidemic of 2014-15 in West Africa. So there are many, many conventions and agreements and obligations that the US, as a member of the WHO, as a member of the UN, and as a signatory to the international health regulations, that we have. And there are many bodies and agencies of the government through which this is expressed. So there is diplomatic collaboration and there's technical collaboration. And part of the technical collaboration, for example, through our CDC, which has been the global leader in public health response for the last 70 years, has been to assist other countries and other regions to do better in disease detection and in the response and mitigation of the impact of those diseases. And so all of this plays out very much into the current situation where we have a global pandemic. And the responsibility of WHO is to define the global pandemic and to remind countries of their obligations under current agreements. And there are many, many activities that the US government supports as part of its soft power around the world that make a huge difference to the mitigation efforts in countries. I'll stop there.
Thanks, Dr. Cleghorn, for a very expansive and very useful answer. Perhaps I could ask either Ambassador Cowell or Ambassador Laskaris about how and what way do you think it may have, those goals may have impacted on how we conduct other parts of our foreign policy, our reputational risks, our ways of obviously leading and not leading the international community.
Yeah, if I could jump in, Ambassador Pickering. Well, first of all, thank you. As you know, diplomacy is made in the Venn diagram of interests and values. And of course, the interest is always protect the homeland, keep American citizens safe. And that includes against the threat of disease. The value, of course, is Americans are compassionate people. They see foreigners suffering from a disease, and the hue and cry is somebody ought to do something about it. And the somebody in this case was CDC and USAID and the State Department responded very effectively. In the case of Guinea, the president of Guinea, Alpha Condé, cut his teeth in Paris in the 1960s and 70s as an exiled student leader in the tumult of that era with a leftist Marxist background. And at the height of the Ebola outbreak, when all of Guinea's erstwhile allies, the Chinese, the Russians, the Brazilians, were running away and disengaging, we were flooding people into the country. We were flooding a 20-person USAID DART team. At any given point, I had 70 or 80 CDC epidemiologists. Raj Shah had come through essentially with a blank checkbook. Tom Frieden had come through from CDC multiple times with the same offer. And I remember one day sitting down with President Condé over lunch, and he's saying, I was a Marxist liberationist my whole life. And all of a sudden, here I am in this life or death struggle in my country, which none of us ever expected. And my number one ally is the United States. And I think that speaks to doing well and doing good as simultaneous pursuits of American diplomacy.
Well, I'd like to chime in there and add something to what Alex has said, and thank you, Ambassador Pickering, for the invitation to be with you tonight. certainly after PEPFAR was formed in the George W. Bush administration, I think it provided a tremendous boost to American efforts and American reputation in Africa. The fact that after many years of seeming neglect, and actually many years after the formation of UNAIDS and the first international response to the AIDS crisis, the PEPFAR program created by the Bush administration really, I think, changed hearts and minds about the United States and Africa in a way that other things had not done nearly so much in the past. So that I think you find to this day that George W. Bush is a highly respected and loved figure in sub-Saharan Africa because of the U.S. response to HIV, primarily under the PEPFAR program, which obviously involved a lot of experts from CDC and from USAID.
Dr. Cleghorn, let me, if I can, turn to you and say, given our role and responsibility, which you've outlined under things like the international health regulations, how are we doing in the present pandemic?
You're mute.
Oh, I am not muted because I want to. Dr. Cleghorn, did you hear my question?
I did hear a question, and I'm about to respond.
Perfect. Thank you very much.
The role of the U.S. in the current global pandemic of coronavirus, a novel virus which first appeared in China in late 2019, that role has been very different from the previous roles of the U.S. in other pandemics. As Sally mentioned, under PEPFAR, the U.S. has been lauded for its global leadership. Under the coronavirus, this seems to be the polar opposite. And while there are still many agencies of government that are involved in international collaboration, the perception of the US's role has changed to what I would refer to as a nationalistic role with America first, and less on the global collaboration efforts that are essential to control a global pandemic. Over.
Would the others like to comment on this? Yeah. Would the others like to comment on this?
Look, when,
if not, maybe I could. Sure, please.
Obviously, no one in West Africa had ever heard of Ebola before, and it turns out that CDC had this massive bench of people anchored by a man named Pierre Roland, a French-American doctor who was the lead. He came beginning within 2 days of the announcement of the outbreak. I took him to see the president. They hit it off immediately, and the president essentially said, "We're going to do whatever this guy tells us to do, as long as we have the money to do it." And so for 2 years, essentially, usually sotto voce, CDC was the lead in policy design, policy response to the Ebola outbreak. And that was a reflection of a broader U.S. government lead, sustained in the case of Guinea by USAID, the DART team, and others. In the case of Liberia, obviously, the deployment of elements of the 101st signaled a pretty strong commitment. So I think that experience cemented the leadership and obliged other countries to follow suit. I mean, the Europeans were in awe of the CDC, as were the Chinese. The Chinese, I think one of their lessons learned was we need our own CDC.
Ambassador Cowell, maybe you could address for us the World Health Organization currently and what changes out of this present pandemic come to light that we might advocate or support to improve WHO performance.
Well, I take it back a long way. Before you were U.S. ambassador to the United Nations, and I was working as a political counselor for Jeane Kirkpatrick, who was one of your predecessors. And as you may recall, Jeane Kirkpatrick was not necessarily a fan of the UN. In fact, in some ways, I think she was trying to build her own political credentials, perhaps for a run as Secretary of State, which of course Madeleine Albright became out of that job. So the more she criticized the UN, the more she was liked and honed politically. So she found many reasons to criticize the UN, and of course there are always good reasons to criticize it. But she never criticized the WHO. And the reason that she exempted the WHO is she would go back to saying, but after all, the WHO eliminated smallpox in the world. The WHO was able to get the smallpox vaccine out and mobilized, and that changed the world. So even Jean Kirkpatrick, a critic of the UN, had tremendous respect for the WHO. Through the formation of UNAIDS, the United States was one of the countries most involved in the formation of UNAIDS, along with the Canadians, the Dutch, the Swedish, and a couple of other essentially Western-oriented countries, because they felt that the WHO's response to the incipient HIV crisis was too medicalized. And in order to deal successfully with HIV/AIDS as a pandemic, it needed an economic response, a political response. It had economic and political ramifications as well. And so the WHO was, in a way, eased out and in a way pushed out of its premier position as the main respondent to a pandemic in favor of a new UN agency being created, working alongside of WHO, but focusing more on this pandemic. Certainly, WHO has some inherent issues of governance, of how it's governed. It's ministers of health who form its governing body, and ministers of health don't often want their own problems exposed before the world, so they can prevent WHO perhaps from taking this out front of position as they ought to when they recognize a problem. But I think, if there weren't a WHO in the world, we would have to create it. I don't see that, the very word pandemic implies that it's something that until all of us are safe, none of us is safe. And the United States has a very strong influence. It can provide resources, it can provide leadership. But I think that until it's working alongside of others in an international body, hopefully and presumably a strengthened WHO, then we won't be able to tackle the next pandemic, which will certainly come along after this one.
Thank you very much. Ambassador Laskaris, two questions for you in a combined way. How and in what way did the Ebola crisis in Guinea impact the way in which you conducted your daily business? How did it change your priorities? And did you see any contradiction between the needs to serve U.S. national security and economic prosperity interests on the one hand, and providing a humanitarian response to friends like Guinea in the Ebola crisis on the other?
The answer to the second part of the question is no, at no time. The answer to the first part of the question is a lot more fun, a lot more interesting. I like to tell people that Guinea is unique in that region because it failed peacefully. All of Guinea's neighbors failed violently. Guinea failed without civil war, which makes it unique in that region, which meant that the state was weak, but the society was strong. The institutions of the state had withered away in the preceding 25 or 30 years, but the traditional institutions of moral authority, led by the Islamic clergy and some of the traditional secular leaders, was stronger than ever, and in many respects had filled the vacuum. And so what we discovered was that our key allies in the fight against Ebola in Guinea were civil society actors. And by that, I mean primarily the clergy. In the case of the forest region of Guinea, the leaders of some of the poros, the secret societies unique to that region. And so we had to retool our diplomacy away from French to half a dozen African languages. We had to retool our diplomacy away from sort of state-to-state contact and much more outreach to the Islamic community on things like safe burials. The main transmission vector in the latter days of the outbreak was unsafe handling of the dead. Obviously, a sacred ritual is a taboo that outsiders can't trample on. On the other hand, though, with CDC reaching out to some of the imams on every Friday, we ultimately got clerical permission to change the way Guineans buried their dead and handled and washed the corpses of their loved ones. And that could only happen in direct contact between the U.S. government and Guinean civil society, and specifically the Islamic clergy, certainly in the second half of the outbreak. But we really had to understand that Guinea was a mosaic of microanthropology, and each one was unique. Each one had traditional patterns of authority that were unique. Each one had its own language, its own funereal traditions, and we had to navigate it. Fortunately, one of the unsung heroes in our response was the Peace Corps staff. Ambassador, you've been in the Peace Corps countries. Unfortunately, we evacuated all the volunteers, but the silver lining to that cloud was I had 15 cultural language teachers with nothing to do, and we got them started on making outreach materials in some very obscure languages, which otherwise the embassy would never have dabbled in. And we got deeply into rural radio stations. We got deeply into SMSing the Islamic clergy. And one of my favorite stories about Guinea was the Grand Imam of Conakry, the leading Islamic cleric of the country, every Friday would send CDC talking points on a gratis SMS system that was an American-owned, run by Israelis, that rented space from the Islamic Endowment of Guinea. And only an Ebola outbreak, when it was all hands on deck and anything goes, made that possible. And Ambassador, you could see how much fun I was having in the midst of this horrible pandemic. I really shouldn't be smiling, I suppose.
Dr. Cleghorn, what do you see as the role of the American medical and scientific community, perhaps outside the official activities, and the promotion, obviously, of our work in dealing in a humanitarian way with pandemics?
Yes. Thank you, Ambassador. First of all, I'd like to say I've spent my entire life in international collaboration with the rest of the world. And there is such a body of both people and resources that come out of the US biomedical enterprise that supports the rest of the world. The US is the leader in new drugs, new vaccines, and new technologies for health. And that connection of making those available to the rest of the world seems to have become a bit broken under the current administration. And I should say that there's still a large body of both medical and research individuals and organizations and universities that continue to do their soft power, collaborative technical work that speaks so well to the investments of the American people in global health. I do think that we have a lot of repair work to do. We were in a very good position prior to this pandemic. And one of the things Sally said, I think is very relevant here, which is that ministers of health don't usually like to air their dirty linen on the global stage. Well, the same applies to the US. And it's not usually the case that we are assisting other countries with the problem that we ourselves are facing at the same time. And so this has muddied the waters significantly, but it does not change the fact that the enterprise of the US biomedical establishment will provide some of the answers to both the response and the mitigation of the coronavirus pandemic. I have no doubt about that. It is going on now.
Thank you very much. The whole question of travel restrictions comes up, and are they useful and effective? And perhaps Dr. Cleghorn would talk about that, but do they affect the efficient operation of our diplomacy? And how and in what way do they have an impact on a global pandemic becoming, in fact, part and parcel of everybody's responsibility around the world, and what can come out of that. For example, the work already begun in something called COVAX on trying to develop priorities and indeed methods and support for vaccine distribution, particularly among some of the lesser developed countries, which is seemingly a general responsibility, but not very high, put it this way, on my sense of our national priorities right now. But hopefully all three of you might have some observations on this. Perhaps I could begin with you, Dr. Cleghorn, and then turn to the two ambassadors.
Certainly. Well, thank you, Ambassador. I see two major questions. The first was about travel restrictions, and we all know that in order for an infectious disease to spread around the world, that it does so through the vectors of human beings. So an interesting and relevant point here is that travel, for all purposes, whether it's leisure travel or professional travel, we've seen an exponential rise in travel around the world over the last 20 years by orders of magnitude. And that has allowed this virus, we have the studies to show it, the virus starts somewhere and then it goes everywhere. This applies to the world as much as it applies to within the United States. The second question you asked, which is how do we get to global collaboration on a vaccine, which is seen as a critical pillar in asserting some control over the coronavirus pandemic. And I think it's relevant to state that we've had some encouraging news this week from Pfizer, which is one of the companies that is developing a vaccine against coronavirus. And that information has just made it much more important to have agreements globally on how effective vaccines, because we expect more than one to be approved in the next 6 months, how do these global vaccines get to the people who need them, both domestically as well as internationally? And there we can state a number of principles. One is that it should get to the people who are most affected first. And a good example of who those people are healthcare workers. I think every country will not disagree that they need to protect healthcare workers first, as well as, of course, the elderly and people with comorbidities. Those need to be protected first. We need some global agreement on this. What we have instead, up to now, has been essentially vaccine nationalism, where countries are trying to purchase advanced market commitments from the companies that are developing these vaccines. And we see a multilateral effort in the COVAX effort you mentioned, which is headed by the WHO along with Gavi, which is the Global Alliance for Vaccines, as well as the Gates Foundation, in trying to develop a framework for those countries that can't afford to pay directly to these companies for doses. They have to go through some kind of joint purchasing mechanism that says no matter how poor you are as a country, we're going to get you enough doses to protect your healthcare workers as well as other vulnerable groups. Over.
Thanks, I'll jump in.
Thank you very much. Please, Sally, before you jump in, let me just tell you that I had the great opportunity in the last years of her life to work closely with Jean, and we did quite a few public appearances. And the only point I would make is Jean mellowed with respect to the United Nations. I'm not sure exactly why, but we never had a public disagreement about it and almost no private ones. And we did many appearances together, including, in fact, sharing the platform with Richard Holbrooke, with whom she got along very well.
Yes.
Yeah.
So please,
very interesting. And let me say it was when we presented I'm saying we in the sense I was the deputy director at UNAIDS working for Peter Piat, a Belgian infectious disease specialist virologist. And we were the ones who had the meeting with Holbrook to tell him about what was happening in Africa about HIV and AIDS, to which he responded that he thought it was greater than a nuclear threat, and therefore proceeded to engage the United States and the United Nations Security Council for the first time to hold a discussion about an infectious disease, namely HIV and AIDS, as a threat to peace and security. I think that's a fascinating change, which has only strengthened through the subsequent pandemic crises of Ebola and now the crisis that we face with COVID-19. So in some ways, I see that as very important that we're moving health to the center of our foreign policy concerns, where it has not ever really been. And now it is, and I think it will remain that. And that's as simple as, healthy is wealthy, even if you live on $1 a day. So health is also pretty important to all of our mission as development. When we brought Nelson Mandela to the Davos Forum in 1996, he said, if you don't do something to the world leaders, the business leaders, he said, if you don't do something about AIDS in Africa, you can forget about development in Africa. So we see that really these two things of security and health concerns and development concerns really are coming closer and closer together and are in fact part and parcel of the same problem. I'm very encouraged actually, and I think it's part of this sort of the extension of this thinking, that one of the first, or maybe the first task force that the incoming Biden administration has named is the task force to talk about COVID. Experts, global or U.S. domestic health leaders to really get together and begin a broader approach toward how are we actually going to have an effective response, including how we're going to allocate vaccines. And in that, I just want to say one more thing, and that's healthcare workers, of course. I think they're extremely important wherever they are. But let's also remember that the countries most in need of a vaccine are those that have very few therapeutic responses available, or fewer therapeutic responses. We see in the United States, even without a vaccine, the death rate in terms of COVID has dropped from 7% a few months ago to 1.2 or 1.4%. I don't remember the exact number now, because we're doing a much better job. We've got massive resources there in ICUs and therapeutic responses. That's not possible right now in many, many, many countries around the world. So I would like to hope that this COVAX group really puts atop of the priority the access to these vaccines by low-income countries. And finally, just a word on travel bans. I think they've never really been effective. I do understand, of course, as Farley says, how much our global travel has increased. But I think locking down the world and preventing travel and normal social intercourse from taking place is likely to be a failure in stopping any pandemic. Thanks. Sorry for the long-winded response.
Let me say on the issue of borders, Ambassador, the outbreak started in a cluster of villages in the tri-border area between Liberia, Guinea, and Sierra Leone, about 8 kilometers from the Liberian border. And CDC got to all 3 presidents, Ellen Johnson Sirleaf, President Karoma, and Alpha Conde, and said, not only is it foolish to close the borders, it's counterproductive. And all three heads of state had the exact same sort of knee-jerk response: close the borders. John Hoover and I got CDC to see the ambassadors, to see the presidents, and said, listen, first of all, the virus is going to cross the border because these kinship ties, linguistic groups are transfrontier anyway, and these borders are fictions if you see them on the ground, which I have. And frankly, if you have a sick person here, you want them to get care. It doesn't really matter where they get care. The important thing is that they get care. And so CDC was able, because of its credibility as the global health leader, was able to leverage all three presidents away from what would have been a catastrophically, economically catastrophically step to close the border and would have had negligible public health impact. By contrast, Senegal closed its border with Guinea in a region that had one case of Ebola over 2 years. And this was entirely panic-driven. And this region of Guinea, they call the Fouta Djallon, their main export market is Senegal. So all of the produce, the famous purple potatoes from the Fouta Djallon you may have heard of, they were all rotting in the fields. And so in addition to a public health crisis, you had an economic crisis and a household livelihood security crisis. So regional border closures are a farcical measure. The travel restrictions in the United States, I give the Obama administration great credit for standing up to a great deal of internal pressure and criticism to not impose a blanket travel ban on West Africa. What they did is they channeled all air traffic through 5 airports, had CDC at all 5 of those airports. And I went through this 3 or 4 times in the 2 years I came home. You had to go through a CDC screening. You had to get a temperature check. You had to be debriefed by public health professionals. You were issued a phone and a thermometer, and you had to call your state board of health. You had to take your temperature and call once a day for, was it 21 or 28 days? I forget. That was far more effective than driving this underground and having to sneak in across the border and infect people, unknowingly. So this notion of closing a border, it's a knee-jerk reaction. CDC's analysis was it's counterproductive and downright cruel, and they were able to persuade 3 regional heads of state to resist that. Over.
I would conclude, Ambassador Pickering, by saying that lockdowns and travel bans are easy but inefficient responses when, in fact, the hard work of mitigation and response is a much more effective way of dealing with the pandemic.
So let me, if I can, Dr. Cleghorn, just continue with you. Christine Lander has asked a question. Going forward, what do we need to do now to rebuild, if that's necessary, CDC and state?
Thank you. I have, of course, a large number of opinions about this. I think the reputation of CDC has been severely damaged by politics. I think that under the current administration, that the 70-year leadership and goodwill that CDC has engendered around the world needs to be rebuilt almost from scratch, because there are now issues of trust over whether CDC, one of the most respected government agencies in the world, there are issues of trust about pronouncements coming out of the current CDC. And this has nothing to do with the thousands of great men and women, scientists and other workers in the agency. This has to do with the politicization of a global pandemic and the politicization of the response to the pandemic in the United States. This will require a lot of investment, the right leadership, and rebuilding some of our bilateral and multilateral relationships in order for trust to be regained. Over.
Ambassador Cowell, I have a question that comes from Jim Dandridge. What coordination challenges exist for U.S. diplomatic missions with regard to regional and international health organizations and cooperation with them during the crises?
That's an excellent question. I would expect no less from my friend, Mr. Dandridge. I think that it's one of the reasons that it's very important for U.S. ambassadors and people outside of the health attaché or the CDC person on the country team to be briefed about health issues, be knowledgeable about health issues, be able to discuss health issues, goes back to the point I was making about how central they have become to our foreign policy and development concerns. So certainly, I think as let's say, a chief of mission in a country which is having an effect of a pandemic, be it Ebola or COVID or the AIDS crisis, really the whole mission needs to get on board with working with the national government concerned, but also with the regional bodies, PAHO in this region and the other parts of the regional parts of the WHO and in other regions, but also with the World Bank representatives and with the UNDP representatives and the UNICEF representatives, so that the entire establishment, be it multilateral or bilateral collaboration, really begins to exchange information and see the crisis from a common point of view, or at least understand the point of view of other collaborators. And again, I think this is something that PEPFAR really pioneered very well, that the establishment of sort of interagency and whole of government and whole of society approaches to dealing with a particular disease. And that understanding, as Farley says, that many of the responses are going to come from the U.S. private sector, from government investment, but we're not going to do it alone. And we will do it much stronger if we do it in collaboration with the multilateral regional health organizations, international health organizations. And I must say with our diplomatic colleagues from other countries which are giving aid and giving collaboration to the host government. They shouldn't be able to play one of us off against another, but at the same time, we shouldn't be duplicating efforts and funding things that they don't think are important or which are not important. So the only way I see around that is by actually having a good, the basis of a good collaboration strategy. It's after all a pandemic.
Thank you very much. Ambassador Laskaris, you've been on the front line in dealing with Ebola in a developing country, in a challenging part of the world. What are the 3 or 4 examples you might give us of learnings that you absorbed that might help in dealing with other pandemics and similar health crises?
Well, the way I used to orient people to Guinea newcomers was it's geographically the size of Oregon. It has the population of Ohio, and it has the national budget of the Montgomery County, Maryland public school system. So Montgomery County, which is admittedly an affluent county, spends as much on K-12 education as the Guinean state. So the first lesson is the Guineans would do whatever we asked them to do as long as it was reasonable. When you're dealing with a pie that's small, you have to modulate your expectations in terms of the resources that Guinea can bring to the table. So you have to start to change your asks of the government more towards the policy side. And someone mentioned lockdowns. What we saw in West Point in Monrovia, the attempt to lock down this urban slum of downtown Monrovia, which I know, having served there, was a catastrophe, and it became a major spreader of the virus. And so one of the things we learned is don't let the host government militarize the response. And the Guineans were tempted over time, really out of frustration, to start arresting people who were violating some of the protocols, who weren't submitting to contact tracing. And with CDC's help, we were able to consistently persuade the government not to deploy the security services in support of an academic. So to me, lesson number 1 is fear doesn't work in fighting a disease in Guinea or in the United States for that matter. So we have to maintain constant pressure on the government to not give in to that draconian impulse to, okay, let's end this by locking everyone down. Second, I think we had to learn that we learned by mistakes. We learned initially our public messaging was all in French. Then we realized that about 85% of the people of Guinea don't speak French. Our initial public messaging was the lethality of the Ebola virus. And then we learned that, well, if we tell people it's lethal, they're fatalistic, and they say, well, I'd rather die at home than go to an Ebola treatment unit. So we had to start, adjusting the message to say that if you get to the clinic quickly and early, your chances of survival are actually quite good. You know, at one point early on in the outbreak, there was a cluster of 25 villages in Guinea Forestière that was denying access to everyone. Young men with machetes had felled trees across paths and were brandishing the machetes at anyone who tried to come into these communities. And so we found an anthropologist at the University of Michigan named Mike McGovern, who had been a Peace Corps volunteer in that area and done his doctoral dissertation on the Pele people. And he said, listen, if young men are brandishing machetes at you, it's because the elders have told them to protect the village. So you have to find an elder, male, who was initiated into the secret societies that Sékou Touré repressed violently in the 1960s, who can speak the secret language of adults and communicate to these people. It turns out there was only one guy in the country who fit the bill. It was the president of the National Assembly. So we airlifted him to this area, and he spoke not only the local language, he spoke the language of the initiated males into these long banned secret societies, and was able to turn the corner. The other thing we learned, unfortunately, and CDC warned us of this, is mortality ultimately educates people. CDC said, listen, this is a terrible thing to say, but when enough people die, attitudes will change. And the goal is to accelerate that process. So in the early days of the outbreak, it was taking us 4, 5, 6 weeks to get access to affected areas. By the last 3 months of the outbreak, we were getting access in under a day. And that's because we kept learning by mistakes. And, you know, one of the mistakes we learned, for example, the safe handling of bodies. USAID DART funded the Guinean Red Cross to do safe burials. They showed up in villages with body bags. All of us who've served in Iraq know that body bags tend to be black. So we showed up in African villages with garbage bags for their deceased. And so we had riots on our hands. So we had to learn, okay, do a quick order, get us white body bags. So really, it's just a process of learning by mistakes and continuing as we go.
It looks like Ambassador Pickering did pop off for a second. I'm going to go ahead and move into the Q&A portion while we try to get him back. So it looks like we do have a question. Let's see. And I'll open this up to anyone. How have the national and multinational COVID-19 vaccine development programs altered the future of vaccine diplomacy?
Well, thanks, Kelly. I'll start off. There has been in the world a huge amount of collaboration in the past on vaccine development and use. And as you know, the polio eradication campaign, the smallpox eradication campaign, we often struggle with some of the newer vaccines that are added to the childhood immunization schedule, where poorer countries lag often by decades behind developed countries in adding these newer vaccines to their immunization schedule. There's no question that coronavirus vaccine development has started off on, as we said before, a nationalistic front. That is, as soon as the virus sequence was described at the end of 2019, many companies, just with the sequence, were able to jump into early vaccine development. And that's a good thing. What you really want is a very robust global effort to try to find the best therapeutics and the best preventives like vaccines. And essentially, if you try to do this, normally this would take 10 years. If you try to do it very quickly, then somebody has to pay for it. Well, as it turns out, the countries with more money and more, as I've said before, developed biomedical enterprise can do those investments. But then we have to turn to our global agreement and state, you're developing this vaccine not just for yourself, you're developing it for the world. Because with a respiratory virus, unlike with Ebola, we are all at risk, even if one place in the world remains unvaccinated. So the very dynamics of vaccine conversation and collaboration hasn't yet been given a full airing at the multinational level. And I think that with the change in administration, we're going to see that airing. We're going to see that we're going to rejoin the WHO. Yes, we can make additional demands on the WHO. And by the way, Ambassador Laskaris, the entire budget of the WHO is less than the Department of Health of the state of Maryland, just to give you a sense of perspective. Okay?
God bless Maryland.
Yes. So I expect to see a flowering of this global collaboration in the very near future that we should all be part of. Yes.
Wonderful.
Dr. Cleghorn, can you hear me?
Yes, I can, Ambassador.
Maybe you could just take up, and then I'll turn to Ambassador Cowell. Tell us what problems exist in testing, contact tracing, and follow-up in terms of quarantine as a preventive step in developing countries and places where the health system is fairly rudimentary. Is this more the practice of more developed countries? And are there things that we could do in a crisis quickly to deal with those problems? Or are they more or less condemned in a crisis to suffer through widespread pandemic infection?
Thank you, Ambassador. First of all, I'd like to say that, as it turns out, the richest countries aren't doing the best job of detection and contact tracing. As it turns out, the US is doing a relatively poor job of that, including in many states that have very, very good public health services. As it turns out, it's really about the commitment to a public health approach that makes you more or less likely to succeed at contact tracing and what I call state-supported isolation and quarantine. If you depend entirely on the goodwill of people to isolate at home, then you're going to run into enormous problems, as we have done in the United States. So we should be clear that it really is about the political will and the provision of the technical expertise and resources to get the job done. And we've seen countries like Korea and Singapore and New Zealand and Australia do really well at this. And that is having enough tests, making those tests available at no cost or reduced cost, and getting results back in time to implement the isolation and quarantine under state supervision that is required in order to control the pandemic. That is what is required. I expect that we are going to continue to do poorly because of this lack of both political will and coordinated resourcing that is required to get the job done.
Thank you very much, Ambassador Cowell. You wanted to say something about the last question.
Yeah, I just wanted to jump in and agree with what my friend Farley has said. I mean, I think political will really is the key. And before, when you Tom, when you asked Farley to address the CDC and state, address rebuilding the CDC and how important that was, but I think equally important to rebuild an institution that the other three of us on this program have been intimately associated with for a number of decades, and that's the Department of State. Because after all, it is about political will and technical collaboration. And we can have the technical collaboration through the CDC, which is important both for us in the United States, but also abroad. But we need the core of U.S. diplomatic missions strengthened to the point where they can play an effective role, or I think it's likely to not be a good international response.
Thank you, Sally. That was, in a sense, a very good wind-up question, which I'm now going to ask the other two to respond to. Ambassador Laskaris, what would you tell us to wind up the meeting from your perspective stands out, is important, or that we need to keep in mind in terms of diplomacy and health crisis?
Look, state hasn't gone anywhere. We're still there. We still have the network. We still have the infrastructure on the ground. What has become increasingly scarce is the CDC presence in Africa. CDC and state took some supplemental money during the outbreak and greatly expanded our footprint on the continent. That has almost all of those gains have gone away. So to me, CDC is the crown jewel of international public health, and I think the leadership once it changes, I think it will be restored to that. The people are still there. I think we need to keep those people out in Africa. We need to keep them in our embassies as health attachés, mentoring and training. And one of the great CDC success stories of the outbreak was the training of several hundred Congolese field epidemiologists who really were where the rubber met the road in fighting the outbreak in West Africa, funded by the U.S., deployed through the African Union with WHO's support. So we just need to keep the CDC presence in the field, in my opinion. Over.
I've lost the audio from Alex Laskaris. I don't know whether he's done or not, but if he is done, Ambassador Cleghorn, would you give us a few words to wind up our session, please?
Ambassador Pickering, we have an enormous job in front of us. We have to find our way out of a pandemic that is only getting worse. And in order to do that, we need leadership, we need diplomacy, and we need material. And all of that has to be based on science. Without science, we will have no impact. And this is the fundamental change that I think we will see in the coming months, that we will revert to a science-based set of policies and actions that will not only mitigate the pandemic in this country, but help to mitigate the pandemic around the world. That is our responsibility. We must meet the moment.
Thank you very much. And let me thank each of you, especially and individually, for your own contributions to the meeting this afternoon, and thank all the members of our audience for joining us. And my thanks particularly to the Diplomatic Center Foundation and to the museum and the project which it supports for having the opportunity to do this. They have a special program called Diplomacy is Our Mission, which explores, for example, Ebola in West Africa, about which we've heard a lot of very valuable information. And so you might take a look at that. The email address for that is on our chat notice here this afternoon. And again, best wishes to you all. Stay healthy and many thanks.
Thank you.
Thank
Yes.
you.
Before we wrap up, I do want to thank you all on behalf of the foundation for being part of the conversation and for sharing your knowledges and experiences with us. For all of you that are joining us, we do hope that you enjoyed tonight's conversation about American diplomacy during a health crisis. While we do offer this program for free, it is made possible through the generous support of our donors, so we do thank them. We know that times are tough, but if you enjoyed this program and wish to help us offer more programs like this, please donate to the Diplomacy Center Foundation by clicking the green donate button at the bottom of your screen. You can also continue to stay up to date with the foundation and future programs like this one by following us online on Facebook, Twitter, and Instagram. Thank you all again for joining us, and please enjoy the rest of your evening. Thank you.
Thank you.